From the JAMA Network, this is JAMA Otolaryngology Head and Neck Surgery Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Otolaryngology Head and Neck Surgery.
Hi, this is Paul Bryson, your host of the JAMA Oto podcast series. I am the director of the Cleveland Clinic Voice Center, and I am delighted today to be joined by one of my colleagues and friends, Dr. Kevin Contrera. He is a head and neck oncologic and reconstructive surgeon at the University of Pittsburgh Medical Center. Dr. Contrera, welcome to the podcast.
Well, thank you very much, Dr. Bryson. It's an honor to be back in my old stomping grounds of Cleveland, albeit virtually, and very fortunate to be able to join you.
Well, it's great to have you on, and it's nice to see you getting your career off and running. And I'm excited for you to share with us today some of your work looking at evolution and current state of neoadjuvant therapy for mucosal head and neck squamous cell carcinoma. This was a review article, correct?
Correct. And it was on behalf of one of the committees for the American Head and Neck Society, which was under Barry Weinig and Joe Curry.
Without further ado, if you don't mind, give us a little bit of a sense for, the motivation for the article, where we've been and where we're at now.
Yeah, I think it's really an exciting time for the field. I think in many ways people have heard about a lot of the advances that have happened within the endocrine space, within the cutaneous space, but sort of the last stone that is being turned over as we speak is for mucosal squamous cell carcinoma. And there's a really exciting trial that's going to be presented at the American Association of Cancer Research. We kind of only have the press release so far, but suffice to say, I think the field is really on the precipice of a major sea change. And I think it's all sort of in this direction of precision oncology.
Even over the arc of your training, even back from medical school through residency, what's changed with neoadjuvant therapy? I know we throw around precision medicine a lot. What are some of the changes that you've kind of witnessed and are now making their way into more, if you would, like standard of care or standard pathways for patients that are newly diagnosed with these types of cancers?
The concept of neoadjuvant systemic therapy is not new. It dates back all the way preceding the VA larynx and the use of it as a tool for bioselection from Greg Wolf and the team at University of Michigan. But the transformation has really taken with the type of agents that we are now adopting. And so everyone's familiar with immunotherapy, and it has now become part of the standard for many other disease sites, including lung, melanoma. Not so much yet for head and neck cancer. It's currently standard for recurrent metastatic mucosal squamous cell carcinoma, but I think that's going to be changing in the near future. And so when you think about the potential of neoadjuvant therapy, in my mind, there's really not a disease site that stands to benefit more than head and neck cancer, because when you look at the functional impact of head and neck cancer, millimeters make all the difference. The difference of taking 30% of someone's tongue versus 20% can mean the difference of them speaking, swallowing, functioning, participating in society. And so there's a real opportunity with neoadjuvant therapy for some patients to be able to adapt their treatment in a way that's personalized and in turn both gives them a cure but also minimizes the side effects of treatment.
As we look to your article, how have you broken down and approached the review?
Yeah, so I think there's a few different ways in which you can think about neoadjuvant therapy. And obviously, the emphasis is on immunotherapy, but it includes immunotherapy with chemotherapy, immunotherapy with radiotherapy. But I think you can kind of think of it as the response assessment, because that is very much something that we take for granted, where of course there's imaging, but can you do a better job with biomarkers or circulating tumor DNA? Then once you've assessed the response to therapy, what next steps can you do to adapt the therapy? We mentioned the concept of bioselection. So people who respond maybe get radiation and chemotherapy, assuming they're going to continue to respond to it. Or do we use it to adapt the surgery? Can you reduce the surgical margin by a responsible amount? Can you hold off or add adjuvant therapy for patients who have a great response or those who have a poor response? And so it's all about sort of breaking down what we know and a lot of highlighting what we don't know. And there's probably more in that latter category than in the first one.
When you talk about bioselection and, like responsible margins, do you have a use case or two that you might be able to share? Like, I've heard different things about response rates with some of what seem to be aggressive, maybe skin malignancies, but are there any use cases that come to mind for you to share with the listener?
Yeah, so I can talk about two cases. And sometimes it's easiest to highlight all the good things, but I'll use the first case as an example to sort of highlight the areas where we need to be cautionary. And I vividly recall when I was a fellow at MD Anderson, we had a patient who, it was a young woman with tongue cancer, which is something that every head and neck cancer surgeon is kept up at night thinking about. And we had used neoadjuvant chemoimmunotherapy. And then on the day of her surgery, she's like COVID positive. It's right in that era. So we would say, okay, we'll do one more dose. She hadn't really had a great response, but we figured we could buy ourselves some time. During that window in which we're trying to shrink the cancer, it actually grows and becomes unresectable. And you can imagine how heart-wrenching that can be. And so I use that because I think it's important that as providers, that this is not a simple matter in which we can just hand the patient off to medical oncologists. I think as surgeons, you have to be particularly engaged. But on the other hand, I can talk to you about patients who I've helped take care of. We have a trial at University of Pittsburgh that uses a combination immune checkpoint inhibitors. And we've seen some major responses in patients such that you go to remove the tumor and there is none left, meaning that there was no viable tumor. And so for that patient, forebodes a excellent survival. In fact, in our study here, any patient who was able to achieve a greater than 50% response, they, so far at least, have not had any recurrence of disease. And so that highlights the exciting parts of this, because I think if you can select for the patients who are going to respond, and then in turn adapt your treatments accordingly, you can really have a parallel impact on patients and their care.
Yeah, do you want to talk a little bit more about selection? I mean, it's very exciting when new treatments and new mechanisms or complementary mechanisms of adjuvant therapy sort of come to market. What's the selection process like? Are these things where from biopsies we're screening for things that might portend a response, or what does that look like?
Unfortunately, we're really still in the infancy of biomarkers. And although there's exciting developments with circulating tumor DNA, we have some. Obviously, PD-1 is one that a lot of people may be familiar with. But even that doesn't necessarily always tell you who's going to respond and who's not. And so I think it has to be a conversation with patients. And there are some smaller tumors where you can get a negative margin with a good functional outcome. Maybe that patient's not necessarily the best candidate, but for medium or advanced stage disease and patients who are interested and are going to be reliable, they're going to come back to their clinic, they're going to go to the imaging to assess response after 2 cycles or so. I think those are patients where you can have the conversation. And I think the responsible thing at this current juncture is to do this in the context of a clinical trial. And for the listeners out there, if there's an opportunity to participate in a cooperative group study or a trial at your own center, that's really the time to do that, because this is still very much in, I would say, not necessarily the experimental, but certainly not the standard of care. And I think with the release of Keynote 689, which was that trial I was alluding to earlier, maybe things will move into the standard of care and maybe immunotherapy can be used. But at this current juncture, the more that we can get patients participating in research, the better we can move the needle and get to some of those other disease sites I mentioned that have made more incremental gains than head and neck.
I commend you on putting the paper together to kind of give people a sense of where we're at the current moment. As you look ahead, certainly clinical trials will be key. Any other important developments that you see in your intermediate term?
I think the most exciting thing is the precision opportunity. There is a lot of work that stands to be done in figuring out which patients are going to respond best and figuring out which agents are going to be best for which patients. There's a lot of different tools at our disposal. There's excitement about immunotherapy, but there are many different types of immunotherapy. And is a combination better? Should we be using it for 4 cycles? Should we be using it for 2 cycles? And so I think at this current stage, we're really in the earliest developments of what's to come. But I do think that it's a really exciting time. And if there's trainees listening or others who are, considering a career in head and neck surgery, I think we need good surgeon scientists to help us figure this out because there's a lot of work to be done.
Well, I really appreciate your time today, and I really commend you on your article and sort of giving us a state of the moment review for where we're at with neoadjuvant therapy right now. It sounds like the future of this is going to be very interesting, particularly with how it will impact surgical treatment and maybe reconstruction too.
Hopefully, our article helps set the stage for what's on the horizon, because I do think there's a lot of exciting developments. But I really do want to express my appreciation to you, Dr. Bryson, and the JAMA Network for your interest and your engagement, and I appreciate the listeners' time as well.
Well, it's been great to have you on the podcast.
Thanks so much.
This episode was produced by Shelley Steffens at the JAMA Network. You can find a link to the manuscript in this episode's show notes. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.